topic for today is diabetes mellitus. So diabetes is a disease that is characterized by increased blood sugar due to poor regulation within the body. There are three types currently. There is type 1 diabetes, which usually affects the young children, and most presentation, they are quite thin. There's type 2 diabetes, usually affects people in between 35 and 45 or above. Most of these patients are obese. And then there is diabetes in pregnancy, which is usually diagnosed between 24 to 28 weeks of pregnancy. So how do you diagnose diabetes? Diabetes is usually diagnosed, there are symptoms and then there are lab tests. So symptoms, usually we have a triad. Triad means three. Usually polydipsia, usually meaning increased thirst for water. Polyphagia, where a patient wants to feed a lot. And then polyuria, where a patient passes urine a lot. Other symptoms that patient might present with is blurring of vision. Patients might have stroke, may have heart attacks. Patient might have nausea, vomiting. Patient might have tingling of fingers and feet, and usually they lack sensation of the feet when they hit certain objects. How do we diagnose diabetes in the lab? One, we usually do RBS, which is called random blood sugar. You can do it any time of the day. The second one, you can do fasting blood sugar, usually early in the morning or when a patient has not eaten. Usually we do around 8 hours after eating. We can do something else called an OGTT, usually done in pregnant women between 24 and 28 weeks to see if the sugars are high. And then there is a test called HbA1c. HbA1c is a test that sees how a patient has controlled diabetes within the last 3 months, and there are cutoffs. If those cutoffs are breached, probably the patient might be having diabetes mellitus.
Under diabetes mellitus, we have acute complications and also we have chronic complications. So we have 3 examples of acute complications. We can have hypoglycemia as an acute complication. So this normally happens when a diabetic patient, a non-diabetic patient, sometimes we may have non-compliance to medication, under medication, or maybe just infection. So when I say hypoglycemia, it's just reduced level of glucose in the blood. We also have another complication known as a diabetic ketoacidosis, and you also have hyposmolar hyperglycemic state. So these are basically some of the acute complications: diabetic ketoacidosis and hyperglycemic hyposmolar state is just basically when the blood sugar levels are being elevated, and so it comes with many symptoms in the patient. On chronic complication, just one of them is cardiovascular diseases. We may have like myocardial infarction, or the commonly lay term known as layman language, heart attack. So these are basically some of the chronic complications, especially when they are uncontrolled or poorly controlled. Diabetic mellitus, when you have elevated sugar in the blood. You also have renal failure as a complication, or maybe nephropathy. Also happens in patients with prolonged or poorly controlled diabetes. You also have retinopathies, or maybe this is when a patient may present with poor vision, or sometimes having issues like cataract, because of elevated or prolonged sugar levels in the body without adequate control. And also another complication is peripheral neuropathy. So this is basically still under uncontrolled sugar levels. A patient may present with tingling sensation, also especially on the limbs, in this state lower limbs, and also numbness on the feet. And also lastly, just to address on the diabetic foot ulcer, because when you have elevated sugar levels in the blood, whenever you have a wound, it takes longer to heal. And so basically you may have a diabetic foot ulcer. So when you go to management of diabetic mellitus, as you know, we have diabetes type 1 and type 2, and so the management also differs. So especially in diabetes type 1, because under pharmacological management or the medical management, because in type 1 there is less or loss of production of insulin in the pancreas. So we basically give insulin injection under diabetes type 1. Under diabetes type 2, we have medications or drugs known as sulfonylureas. One of the examples is metformin and also glabiclazide. We also have dietary control in diabetes mellitus because we want to control the sugar levels, and so we also want to control the portion of the foods taken from the morning, lunchtime to evening. So with the large chunk of vegetables and a little portion of carbohydrates, and as well proteins. And also we have exercise as one of the of the management under diabetes mellitus. And lastly, we also just love to address the concern of, especially on insulin, on in terms on storage, the storage of insulin for it to have the proper efficacy, for it to work under insulin injection. So storing it under controlled low temperatures for its efficacy to be prolonged.
With the consideration that in most instances the diagnosis is incidental and medications may be started at the point of diagnosis, or follow up the patients for a short time on other management options such as dietary management, recommendations of exercise, reduction of alcohol, or total avoidance of alcohol intake and reduction of smoking. Depending on the management that has been instituted at the point of diagnosis, patients will mostly require to come for a clinic checkup within 2 to 4 weeks after the diagnosis is made. The point of these very early visits is to check for glucose control, whether the levels are within the required levels, that is for both fasting and the random, which are the 2 hours postprandial sugar levels. Depending on the type of diabetes that has been diagnosed, we would want patients to check their sugar levels either regularly on a daily basis, or at least 3 to 5 times a week, depending on the accessibility of strips and a glucometer, whichever will be appropriate, or depending on clinical judgment. Besides checking for glucose control levels, the other most important thing is medical examination. Now, diabetes mellitus affects literally every system in the body, and the point of medical examination is to identify any complication or any manifestation of systemic involvement of diabetes mellitus in the disease process. From the neurological perspective, we'll want to check for any neuropathies, any areas of ulcers, the neuropathic ulcers that most commonly affect the feet. We'll want to examine the cardiovascular system. We'll want to examine the abdomen for any organomegaly or any abnormalities, the skin for any skin changes. Some pigmentation of the skin does occur in diabetes mellitus, and the other systems. The other thing that we like to assess is for any concerns that could be arising at that point, whether you have good access to medications, whether there are any concerns like access to food, access to the medications, like we had said, storage facilities, and any other concerns that may require medical attention at that point. Now, depending on the control that has been attained, the follow-up duration after that may be prolonged to 3 months or to 6 months, again based on a clinical judgment. During these follow-up visits, there are some laboratory studies that may be required for checkup. One of them is a creatinine check. For example, if you are on metformin, it has some effects on the kidneys, and we may require to check for creatinine clearance just to ensure that your kidneys are not involved. The other thing we like to assess for is the lipid, the lipid profile, which has been shown to have an added effect in the cardiovascular and cerebrovascular morbidity in patients with diabetes mellitus. And then if they are deranged, then there are medications that can be started to ensure that the levels are within the normal limits. Other laboratory investigations will depend on clinical judgment and clinical presentation at that point. This may include thyroid function tests. They may include lab work, complete blood count, workup for infections, and even imaging, especially angiographies of the lower limbs to check for any vascular involvement in cases of vascular damage of the lower limbs, which is a common finding. Foot care is also emphasized in every clinic visit, and this involves wearing shoes that are a bit bigger. They should not squeeze the feet, ensuring that they're rubbery or mattress-like sole component, and ensuring hygiene, especially in the interdigital areas, to ensure that there is no infection in those points. And a neurological examination of the lower limbs of the feet will be done at every visit. This helps us to ensure that there are no complications arising, and if any arises, then we can manage it as appropriate. Patients with diabetes can lead normal lives with well-controlled blood sugar levels, with no complications, and they can live their normal lives just like everybody else.